You're wondering what this has to do with psychotherapy, but it's coming. The fishermen have to decide whether they're going to go out and fish each day, okay? Because it's dangerous, they could perish. So you would think from evolutionary theory that this is evolution or survival of the fittest fisherman, right? The fisherman who has the best sailing skills and has the best judgment is going to survive longer and thrive than are the less skilled fishermen. But this isn't what the fishermen do in Loarca. They actually get together on the foul weather days. And this is a picture I took when I was there of a mural in the town. And you can see on the table is a boat and a house. So if the fishermen want to go fishing, they put the token by the boat. If they want to stay home, they put the token by the house. If the majority of the tokens are by the house, everybody has to stay home. So this is a social decision by the fishermen. And this is what E.O. Wilson calls as evolution of the fittest social group. So Loarca had an advantage over other fishing villages because they used this cooperative behavior in order to survive. So Loarca thrived because they made the decisions based on what was best for their village, not what was best for each individual fisherman. And E.O. Wilson called animals that make decisions based on social systems ultra-social or EU-social animals, of which, of course, humans are the prime example. Well, given that humans have evolved to work in social groups, it's not surprising that there's actual healing in a social context. Well, ants heal in a social context. If one of the ants in a colony is sick, infected with a pathogen, you have an idea what they might do. So they turn the lights down. I can't really see whether you're thinking of things they might do, but they have this what would seem like odd behavior where every ant in the colony slowly and sequentially rubs up against the sick ant. Any idea why they might rub up against the sick ant? Well, this transfers a small part of the pathogen, or a small amount of the pathogen, to the healthy ants, which creates an immunity. So they call this social inoculations. And every healing practice of an individual organism is expressed by the ultra-social animals for healing in a social context. Bees do it. If there's an infection in the hive, bees flap their wings really fast, frenetically, okay? Again, seems a little strange, but what it does is it raises the temperature in the hive, okay? And we know that fever fights infection. Oh, again, a social example. So what do we do when we're hurt? Cross-culturally, we all make the same facial expression. And it's a signal when you're hurt for social assistance. Okay, if you're out hunting in prehistoric days and you're injured, someone needs to take you back to the village, okay, and tend to you. So that facial expression, which evolved about 10,000 years ago, was a way to elicit social support for healing. Every single human civilization from the beginning has had healing practices. A designated healer, somebody who was set by the society as the healer, and a set of practices that were accepted. Okay. So we heal in social context. And in fact, our social brain, our large brain, is actually evolved not to invent things like the internet and airplanes, but to manage social situations. So this is a graph that correlates in primates the size of the social network and the size of the brain. Okay? So the larger the brain, made to manage larger social networks. Okay, how many people know not to do this? Okay, raise your hands. Yeah, we all know not to do that. Well, how many of you learned this by classical conditioning? Yeah, there's always one or two who did this as a child, right? Okay. So Pavlov would say that's the way you learn not to stick a knife in the electrical socket. How many people learned it through Bandura's vicarious learning? You saw somebody else do it, and you learned that way. Okay, there's one. That's good. Most of us learned by verbal persuasion. Somebody who was a significant other, likely your parent, told you this was dangerous, and you decided that you weren't going to do it because it was dangerous. And that's the way we as humans learn almost everything, is through verbal persuasion. So let's make a few more distinctions before we get into how psychotherapy works. Let's make a distinction between disease and illness. Disease is something wrong with the organism, okay? It's a pathophysiological phenomenon, which is very different than an illness, which is the lived experience, your experience of life. It may be about a disease, but it's often about some kind of distress. Okay, let's talk about a few other things. Natural healing. So this is a study that I found on the internet, of course, of the number of microbes on a door handle. So many of you have opened doors today, right? Millions of germs, okay? But we don't get sick because we have this natural healing process. We have an immune system. Our blood coagulates when we get cut, okay? So this is healing unmediated by technology. Then we have technological healing. And technological healing is interventions that remediate that pathophysiology. So sickness is something that's wrong with the organism. Technological healing fixes it. Okay. In the technological healing, the patient's passive. We do something to the patient. And there's a picture of surgery, right? The patient in surgery is often passive because they're anesthetized. Okay? But we also have technological healings in medications. And this is a medication on the right. Anybody recognize fluoxetine? So there's a chemical structure for Prozac, and we take it, and that's the technological part of healing. Of course, this is Western medicine, okay, is technological healing. But the kind of healing we're interested in is interpersonal healing, okay? Here it's based on the human interaction with an active involvement of the patient. The patient is doing something in order to feel better or solve problems. So it's a conscious patient making meaning of their experience with the healer. And the interpersonal healings focus primarily on illness rather than disease. Okay. So psychotherapy, that's a long introduction to say psychotherapy is a healing practice based on verbal persuasion that occurs in a social context. So what do we know about psychotherapy? Well, we know it's effective. Okay, it's demonstrated in randomized clinical trials, and in practice, practicing therapists get outcomes comparable to randomized clinical trials. Talk therapy, just meeting with a therapist and doing something, as effective as medications for most mental disorders, okay, primarily tested in anxiety and depression. But psychotherapy is longer lasting. When you withdraw medications, people relapse at a greater rate than people relapse from terminating psychotherapy. Of course, fewer side effects, right? You don't get loss of libido and weight gain from psychotherapy. And psychotherapy is less resistant to additional courses. If someone completes psychotherapy the next time they go, there's still a high probability it's going to be effective. Well, the NNT of psychotherapy is 3. NNT is the statistics that evidence-based medicine loves, okay? So NNT means number needed to treat. So it's the number of patients that have to get some kind of treatment in order to have one additional success. So the NNT of psychotherapy is 3. That means for every 3 patients seen in psychotherapy, 1 has a better outcome than they would have had not coming to psychotherapy. Well, that's kind of depressing, right? That means 2 out of the 3 people we see aren't going to have a better outcome. But actually, if you look at NNTs for many common medical practices, they're much higher. Okay, flu shots is 12. Aspirin as a prophylaxis for cardiac events is 100. Okay, most cardiac interventions, asthma interventions, are about 13. But clearly, there's room for improvement. And at the end of the talk, I'm going to mention how we might get better. And therapists are not aware of their failures. So Mike Lambert's research indicates that when they identify failing cases on the outcome questionnaire, very rarely are therapists able to identify those cases. So the question is, what makes psychotherapy work? And here I'm going to present a relationship model based on relationship factors. The important part of this model is that there are multiple pathways, okay? And I think as clinicians we know psychotherapy doesn't work in just one way. We're doing many things at the same time. This model emphasizes the common factors, but as you'll see, it integrates the specific ingredients. So the common factor model I'm going to present contains this idea that the therapy is doing something specific. As it turns out, it just doesn't really matter much what particularly it is. Okay, there's the model. I'm retired from my job as professor, but we get paid for making these kind of diagrams. I'm going to explain each of the pathways, and the important thing again is to indicate that there's multiple pathways for doing this. But before you even begin making change, you have to meet with a patient and form a relationship. And this is kind of a daunting task because people are evolved to discriminate between those they can trust and those they can't. So the example I usually use is arriving in a foreign city where you don't know the language very well, it's late at night, and you don't know your way to the hotel, and you walk out in the street and you have to ask somebody for help. Well, you got to decide pretty quickly, is that person going to give you directions or maybe take you to the hotel? Or is that person going to rob you of everything you have? And it turns out from some pretty interesting studies that in 50 to 100 milliseconds, you make judgments about whether someone's trustworthy. Okay. So when a patient sits down in front of you, before you've even taken your seat, there's a unconscious, out of awareness assessment of whether you're trustworthy or not. Of course, it's not all that bottom-up processing. There's top-down processing because people come to therapy with some beliefs about what's going to happen there, with some faith that it's going to be useful. Maybe a friend recommended this particular therapist, or maybe there's some diplomas on the wall at prestigious universities, so you're impressed by the credentials of the therapist. So there's some top-down processing as well. When do most people drop out of therapy? Yeah, after the first session, okay? Second most frequent time is after the second session, and so on. So people are making an assessment very quickly. Is this going to be useful? Do I want to spend the time and money and effort that it takes to be in therapy if I don't have confidence it's going to work? Okay, first pathway is this real relationship, and the real relationship is defined in kind of a psychodynamic way as the transience-free, genuine relationship based on realistic perceptions, which is a really nice way of saying it's two people meeting, having an intimate, genuine relationship. Okay, so as a kind of exercise to see why this is so important, I've pictured some risks for mortality. We know that obesity, lack of exercise, environmental pollutants, and smoking are bad for you, put you at risk for death. Do you know what's as great or greater risk for death than any of those? Loneliness. Yeah. So one thing we provide in therapy is, particularly for patients who have disordered social relationships, poor attachments, we provide an enduring, empathic, understanding relationship. And we shouldn't underestimate the importance of that real relationship for patients. Again, psychotherapy is uniquely enduring. Okay? Patient can tell us they've had an affair. They can tell us about shameful things they did. They might even tell you, well, you know, I'm here because I'm a pedophile. Okay? And what's the contract we have with them? That we're going to be there for them, with some exceptions, the next week. And not just be there sitting there, but doing it in an empathic way. That's pretty unusual to have a relationship like that. Interesting, treatments with only relationship factors are remarkably effective. In clinical trials, the comparison groups are often called supportive counseling or Rogerian therapy, where the therapist is only allowed to be empathic, nothing else. No advice, no work on cognitions or affect, no strategies for overcoming problems, just sitting and being empathic. Okay, so here's the science. These are effect sizes for aspects related to the real relationship: empathy, positive regard and affirmation, congruence and genuineness. Okay, what we think of as the Rogerian conditions. And if you look at the size of the effects for these factors, they're really large. We won't go into the numbers too much, but 0.5, 0.6, 0.7 are robust, substantial relationships. Each of these effect sizes are from John Norcross's book, Psychotherapy Relationships That Work. Okay? And they're based on meta-analyses, so they're pretty robust findings. Okay, let's look at the second pathway. Second pathway is expectation, and we know that expectations have a strong influence on well-being. What you expect to happen influences what you experience. So you go to a restaurant with a 5-star rating by the restaurant critic, and there's people waiting in line, and everybody sitting at the tables looks really satisfied and happy, is going to affect our experience of eating in that restaurant. And we know mostly about the power of expectations through placebo research. And I'm not going to go through this in too much detail given the time, but we know a lot about placebos. If you give someone a painkiller, or tell them it's a painkiller, but it's only a sugar pill, they're going to feel less pain. But they're also going to release endogenous opioids. So it's not just a subjective report, it actually changes the physiology or neurology of the patient. My colleague has subjects taste really disgusting tasting liquids, and then he does brain scans, taste cortex lights up. And it's interesting because the taste cortex was thought only to respond to the taste in the mouth, so directly wired to the taste cortex. But he also gives them placebo liquids that after they've had several trials of this obnoxious tasting, and they get the same activation in the taste cortex as if they had had the noxious tasting. Okay, I'm going to skip this to my favorite one, and that is exercise and fitness, because we'll all like this. You're sitting down now, you're not doing much. But if I told you that what you did made you fit, you walked up the stairs to get here, would you believe you're more fit? Well, they did this with hotel workers, randomly assigned half to a condition where they told them, you know, what you do every day as a hotel worker makes you more fit. Okay. The other group were told something neutral. Okay. Well, those people who were told that this work really makes you fit reported being more fit, but their blood pressure was reduced, their body mass index was reduced. They were more fit just by being told. What you do makes you fit. Yeah, I know, I see some people going, amazing. Okay. I'm going to skip this slide and go back to expectations. So the way we create explanations or expectations in psychotherapy is from the explanations we give. Okay? What we tell patients about how psychotherapy works. I've never been to psychotherapy. How is this going to be helpful? And we explain psychoeducation and explanation for what's done in treatment. We go, oh, I get it. I see how this is going to be helpful. And of course, just saying that this pill will make you feel less pain isn't sufficient. You actually have to take the pill, and the same is true in psychotherapy, actually have to do the work of psychotherapy. Well, this explanation is most powerful when it's created in interpersonal interaction. Okay, I'm going to skip that part because I'm running a little bit behind. But let's skip to the alliance. And the alliance is agreement about the task and goals of therapy. And we can see that, again, goal consensus and collaboration and alliance highly related to outcome. There really isn't anything that's been studied as much as the alliance. Hundreds and hundreds of studies, thanks to Lesson and Adam Horvath's work, and robust across therapies. Okay, it's not just humanistic or experiential. Cognitive, behavioral, and even psychopharmacological treatments rely on the alliance. Okay, here's an interesting study. I don't want to show too many studies, but this one really illustrates what's going on. And this indicates the interaction of pathways 1 and 2 of the model. So this is a study of irritable bowel syndrome, a fairly common syndrome in primary care context. And in this study, they're looking at acupuncture placebo. Okay, it's not real acupuncture because the needle doesn't pierce the skin. Okay, so it's not invasive, but the patient believes they're getting acupuncture. And this acupuncture placebo, which has been shown to work for IBS, irritable bowel syndrome, the patients were randomly assigned into 4 conditions. The wait list or treatment as usual, so they're getting care from the primary care physician. A limited interaction condition where the acupuncturist comes into the room and says, your doctor ordered acupuncture, I'm an expert in acupuncture, and delivers it. Okay, just matter of fact interaction. The third condition is what's called this augmented interaction, or what the authors called the optimal healing interaction, where the acupuncturist was warm, empathic, and caring. Just gave statements that would indicate they understood how difficult it was to function with irritable bowel syndrome. No interventions, no coping strategies, just warmth, empathy, and understanding. Okay? Well, the results? In each of the conditions, the placebo worked. Okay? But giving it in a warm, empathic relationship often doubled the effect. So it's hard to see, but the lower right is quality of life. So here the acupuncture really, what the placebo acupuncture and the limited interaction, barely better than the treatment as usual, but given by a warm, empathic healer. Okay, really augmented it. So this is placebo effects or expectation effects given in a warm, empathic relationship improves. Okay, so the last pathway are the specific ingredients. So agreement about the tasks and goals of therapy leads adherence to the protocol. What each of the therapies does with specific ingredients is to get the patient to do something which is health promoting. In CBT, you think about the world in more adaptive and appropriate ways. In interpersonal therapy, you work on your interpersonal relationships. In affect-oriented therapies, you experience and express important affects that are useful in your life. So all therapies induce the patient to do something helpful. It turns out unstructured treatments without any therapeutic actions are less effective than cogent, focused treatments. So the greater the patient understands how the therapeutic actions are related to benefits, the more effective it will be. Are some ingredients more potent than others? Well, not all treatments are effective. I don't have time to show stop-it therapy, but get this on YouTube. It's Bob Newhart. His therapy, it lasts 5 minutes. He just tells the claustrophobic patient, stop it. She goes, what do you mean? Stop it. Okay? Well, that's not an effective therapy. So not all therapies are effective. We can design ones that don't work. But all treatments given by therapists who are trained to give them, believe in them, have cogent treatment principles work equally well. So we're going to skip the evidence, but you can read about this. Every single disorder I've looked at, as long as more than one treatment has been studied, they're all equally effective. It goes from depression, anxiety disorders. I just got done reviewing the meta-analysis of psychosocial treatments for schizophrenia. Absolutely no differences. Okay, if you look at the outcomes for the specific ingredients, we didn't go through all these, but the, let's see, we have treatment differences, at most a small effect. Specific ingredients, dismantling studies, if you take out the work on cognitions from cognitive therapy for depression, it still works just as well. 2 meta-analyses now show that. Adherence to the protocol, the more you follow the manual, treatment's not better. And surprisingly, rated competence is not related to outcome. Okay, so for the remaining 10 minutes, I want to talk about therapists, okay? Most of us are therapists in the room, and I talked about this morning a little bit. I titled this slide The Forgotten Factor, but it's not forgotten by therapists and it's not forgotten by patients. Who forgets about it? Researchers, okay? There have been tens of thousands of clinical trials of psychotherapy. None of them have included therapists as the goal of the randomized clinical trial. So the definition of therapist factor is some therapists consistently get better outcomes than other therapists. I don't think anybody really doubts that, even the most hardcore CBT clinical scientist, because when they recruit therapists for their trial, they take the very best therapist they can find, because they know it makes a difference. Okay. We want to compare the size of therapist effects to other factors. How important is the therapist? And can we identify the therapist by observation? So I'm going to show you some therapists, and you point to the one who's the best. Well, they're not therapists, they're baseball players. And I use baseball players because we have so much statistics on baseball in the States. Well, look, they're all different. Here's Ichiro Suzuki, he's a CBT batter. Here's psychodynamic batter. This is emotion-focused batter. This is systemic batter, okay? There's lots of ways to do this. By looking at therapy, you're not really going to be able to tell, or looking at therapists, who's the best therapist. Okay, what's the evidence for therapist effects in clinical trials? About 3% of the variability in outcome is due to therapists. You know, in clinical trials, we get the best standardized conditions, patients are selected and so forth. And 3% doesn't sound like a lot, but we'll see it's pretty significant. In naturalistic settings, it's greater, about 7% of the variability in outcome is due to therapists. And this is true regardless of treatment, so it doesn't matter what the treatment is. And it's more important than the treatment, so if you look again at our graph, therapist effects, between 0.4 and 0.5 compared to treatment differences, which at most are 0.2. That's an overestimate. That's the upper bound. Okay, let's go back to baseball for a minute. In the short run, the hitter matters very little. Okay, so we have these batting averages, and I know most of you are not baseball people, but a 275 hitter means 27.5% of the time they get a hit, okay? Versus a 300 hitter, not very much difference. In fact, it's only 1 hit every 2 weeks. That's 12 hits a year. It's only 180 hits over a 15-year career. So it doesn't sound like a big difference. And in fact, if you watch both players in 15 games, there's a 40% chance the poor hitter is going to have more hits in that game, okay? Because there's lots of other factors, like how good the pitcher is, okay? And this is the same of therapist. If you want a therapist to look good, get a good, motivated patient who's ready to work, Okay, so 275 hitter versus 300 hitter, not a very big difference. How much more money does the 300 hitter make than the 275 hitter? Per year. $13 million more paid to the 300 hitter, okay? Well, there's an analogy here. You only have to be a little bit better as a therapist to help lots more patients. So in a study we did some time ago, the top 25% of the best 25% of therapists, the top quartile, had twice as large effects in the following years than the bottom quartile. Okay, and when I say the top 25%, top quartile, based only on their outcomes. Okay, we didn't watch them in therapy. We didn't know anything about them other than their outcomes. So good therapists consistently are good. Unfortunately, in 3 years of data, some therapists never helped a patient. Every single one of their patients deteriorated. Okay. Saxon and Barkham in the National Health Service data, if they took and reassigned the nearly 2,000 patients for the bottom 19%, which they call below average therapists, and randomly assigned them not to the best therapist, but just to the other therapist, an additional 265 patients would have recovered. Okay, so a small difference, 7% of the variance in outcomes, makes a big difference when you look at the actual outcomes. Psychiatrists' effects in psychopharmacology, okay, giving an antidepressant. So this is the reanalysis of the NIH depression study in the 90s. And this is antidepressant versus placebo. The psychiatrist met with the patient 30 minutes every other week, not very much time, okay? 3% of the variability in outcome was due to whether you got an antidepressant or not. Doesn't sound like very much, does it? That's the usual separation between antidepressants and placebos. And we know drug companies made billions and billions of dollars based on that 3%. How much of the variability is due to the psychiatrist who gave the antidepressant or the placebo? %9. So 3 times more important is the psychiatrist who gave you the pill as opposed to the pill. And in fact, the best psychiatrist got better outcomes giving a placebo than the worst psychiatrist got giving an antidepressant. So your advice is go to psychiatrist X and ask for a placebo. Okay. We got time just in the last few minutes to talk about, well, we can't leave without saying if some therapists are better than others, what do? Okay? And if you look at Larry Butler's chapter in the Handbook of Psychotherapy and Behavior Change, he said, we don't know and we don't care. Yeah, this is my example of a poor therapist. So can we recognize effective therapists? It's a really difficult thing to do, actually. Tim Anderson did this really intriguing study. Remember, we can't really watch them and see what they're doing because the patient contributes so much. But what Tim did is he showed video clips of really difficult patients and asked therapists to respond, okay? And then he rated the response of the therapist on these interpersonal skills. And he found out this is what differentiates more effective therapists than less effective therapists. And he called them the facilitative interpersonal skills, verbal fluency, how well can you express yourself and how interestingly can you express yourself, how well can you perceive affect, even if the patient is avoiding it or not experiencing it, affective modulation and expressiveness, and when I do video clips of this, I show Les Greenberg as an example of how to modulate expressiveness. Warmth and acceptance we've talked about, focus on the other, makes sense. Tim Anderson even did this in a prospective design where he looked at psychology trainees in their first week of training before they'd learned anything about psychotherapy, gave them the same video clips, and he could predict, based on their response, without any training, of how these therapists would perform with patients 2 years later. Absolutely incredible. Can therapists improve? Do we get better with time? Okay, I'm hanging out with a lot of people of my generation. We think we're smarter and wiser. But what the data shows is, and this is from 18 years, looking at the same therapist over up to 18 years, therapists actually deteriorate. Yeah, we laugh, but it's nervous laughter, right? Because this is disturbing. Well, if we're going to get better, we have to do what all experts do, and that's deliberate practice. We have to practice our skill, okay? And I have some quotes. I'm just going to tell you one of them. Pablo Casals, when he was 80, they asked him, why do you still practice 4 or 5 hours a day? And you know what his response was? I think I'm still getting better. Okay? How many of us practice therapy? Now, when I say practice, that means outside of the actual meeting with clients. So here's actually a different graph, and it's the last one I'm going to show is, this is the Calgary Counseling Center in Canada, where they use deliberate practice to help therapists get better. And if you look at their outcomes over time, they're actually improving. So as opposed to the previous example of therapists who, by the way, were getting feedback. Okay, here they do deliberate practice. So the conclusions, the common factors, and treatment are embedded in a meta model, the contextual model. Common factors are absolutely critical to outcomes, and they give the specific ingredients their potency. The specific ingredients are important, but it's the way they're delivered that makes them work. Okay? And the therapist who delivers the treatment's more important than the particular treatment. So we shouldn't be arguing about what's the best treatment, but we should be identifying and helping therapists improve. Okay, thank you very much.